panel. I'd like to ask our second panel to come on up to the stage, and while they're getting settled, I'll introduce them and we'll get right into this focus on accountable care and innovations, disruptive innovations in diabetes care in the United States. You've just heard about a number of distinct innovative approaches to improve diabetes and complex patient care around the world, as we're going to turn to now with some of the U.S. case studies that you've seen for this event. This is also happening right here in the United States, and we're going to talk about some of the similarities and potential differences between the international and U.S. experiences and identify potential areas of common ground and ways of supporting more effective transformation more quickly. With all of this in mind, we've got a diverse panel joining us today. Steve Fitton on the end is the Medicaid Director for the State of Michigan Department of Community Health, who's been involved in a range of initiatives underway there in the state Medicaid program to shift towards more of a community and early intervention focus for chronic diseases like diabetes. Greg Long is the Chief Medical Officer at Theta Care, as you've seen in the case study, has long been engaged in a number of innovative approaches to promoting population health as part of an accountable care organization, and is in the process of launching and expanding a program focusing on complex patients like those with diabetes. Jose Pena is the CEO and Chief Medical Officer of the Rio Grande ACO in South Texas, dealing with a challenging population from the standpoint of high incidence of diabetes, limited incomes, and many of the issues that contribute to a high burden of diabetes complications and high healthcare costs in programs like Medicare in that region as part of an accountable care organization effort to address that. And Chuck Saunders is the CEO of HealthaGen, affiliated with Aetna and part of a wide range of, where he's leading a wide range of initiatives involving medical homes, accountable care programs, other supporting initiatives to help healthcare providers transform care. So as with the last panel, we're going to start out with just a little bit of overview of some of the main things that are going on in these programs. I think what I'd like to do is start with our two healthcare organizations, with Greg and Jose, to describe what they're doing. Then I'll ask Chuck and Steve to provide a little bit of a context from the private and public payer side on how they see their policies supporting and potentially encouraging some of the innovative approaches to care delivery that are being implemented here in the United States. And then we're going to tie this back in the discussion to some of the things we've heard about from an international standpoint. So Greg, if I could start with you. Maybe just a few brief points about some of the main features of the initiative that you're undertaking at Theta Care, why this is such an important effort, and what you see as some of the key challenges in accomplishing your goals.
Sure. Thanks, Mark, and thanks for the invitation to share, and to the staff for helping put the case study together. Really, from three key messages on what we're working on, probably the most important is we've had a fair amount of experience working with the CMMI Pioneer. We've been in that for the last few years on a large scale. What we're really trying to do now is become much more focused in what I call a inside-out population health, where we're really focusing on our highest risk population, with obviously diabetes being a big part of that. So we're working with two of our primary care clinics. We've stratified our patients. We've identified that top 5%, which in those two clinics is roughly about 1,800 patients. And really what we've tried to do is take, with some of our lean innovation background, worked an innovation model to come up with what is the best way that we can now address this population with their healthcare spend, us not being able to get them to their outcome targets. So really we're focused on this multidisciplinary team-based care approach. That in and of itself is not innovative, but I think trying to put that entire team together and do it on a larger scale in a large healthcare system, I think is what we're finding is the challenge. Part of that is we enroll patients in this process. We now have 100 patients that we've enrolled in that, and we actually literally take a team of different providers, including behaviorists, pharmacists, clinical care coordinators, and put them in a decentralized model right in the primary care setting. So that for us is very unusual. As you might expect, it's a much more costly model if you make no other additional changes in how you manage the rest of your 95% of the patients. And right now we don't get reimbursed for that particular model. So that inside-out population approach really is heavily focused on ambulatory care. We really try to minimize the use of acute care settings, very strategic use of our specialist partners. So it really is very heavy on primary care and a new team-based approach. And with that, as you might expect, that isn't what physicians went to medical school or residency training to learn how to do. So that is probably one of our number one barriers, is to help them figure out how they can be much more of a team leader versus I have to do everything by myself. So that's going to require compensation changes, a much more intensive connectivity with patients, less face-to-face, more time with care coordinators, pharmacists, RNs, NPs, and PAs. And so it's going to be a much different model, but it was eye-opening to me to look at statistics within our own family physicians and internal medicine. In any given year, they would have about 500,000 patient visits, and you look at our acute care settings, we had about 28,000 discharges from hospitals. So it's like, the care is happening in the ambulatory setting right now. We just want to figure out a way to make it more robust, minimize the need for the hospital admissions, dramatically decrease the utilization. So that's really kind of the number one thing that we're working on. And then really sort of the two other issues are, our payer relationships. How can we work more closely with payers, help them understand the model that we're working on, and hopefully get back to some sort of a semblance of a risk-adjusted capitation model. Even right now, what we've discovered in the work that we've done in the Pioneer is that we're almost at the bottom, at least in those comparative organizations, with our cost per Medicare beneficiary. I think this last reported year is about $8,400 per beneficiary. So our concern is, as we keep ratcheting down that cost, a shared savings type model or anything to do with how you bend the cost curve is not really going to adequately pay for this model. So we really need to get back to some sort of a risk-adjusted capitation or percent of premium, where we can take those dollars and really focus on our care. And then the other thing that we have probably less direct impact on is the policy reform, on a much larger, broader scale, working towards a more rapid, advancement in payment reform to get to, again, less shared savings in this type of a model and more around risk-adjusted capitation or percent of premium. So right now, to fund this, one of our biggest obstacles is internally. This is costing us money. At the same time, we're decreasing our utilization, which right now is revenue. So we're actually looking at a lot of external grant opportunities to at least help get us through this proof of concept phase, to at least show to our CFO and CEO that we can afford to do this and not take too much money out of the bank and shooting ourselves in the foot in the process. So,
Greg, thanks for the overview. And just to push on this, that you've emphasized the importance of reimbursement or the lack of reimbursement for many of the team-based and preventive approaches that you're taking. I think a lot of people hear about Pioneer ACOs and ACOs generally think, well, that's payment reform, isn't it? It sounds like you're saying it's not enough.
Well, it's not. And again, I think there's systems across the country they're at different places. Fortunately, in the upper Midwest, we've had 10, 12 years of experience, if not longer, of trying to get healthcare costs more under control. So when you kind of start out in a lower range, a shared savings model, as an example, you're just not going to cover the cost or your reduction in revenue. The other thing I just found out recently is even if you look at incremental changes like the CMS chronic care management fee, every individual that may want to take advantage of that still might have an $8 copay. To us, we're going to manage those patients the same anyway, whether a Medicare recipient chooses to go that route and we get the money or not. So incremental changes just don't seem like they're going to support this type of disruptive innovation, if you will.
We're going to come back to that disruptive innovation. Right now, I'd like to go to Jose, though, and Jose, I think your region got some fame a few years ago when Atul Gawande wrote about it as not the case, as is in the upper Midwest. Actually, some of the highest Medicare costs in the country, some of the highest complication rates and rates of chronic serious conditions like diabetes. So not the situation that Greg was describing. And can you tell us about how you've changed that? I mean, it came through very clearly in the case study that you're really implementing a fundamentally different model of supporting patients with diabetes and other chronic conditions.
Thank you for the invitation, first of all. Yes, we are coming from a different part of the country and different spectrum of cost of care and the population. Part of the high cost in our area is that we have about 45% of dual eligible, and the dual eligible cost is similar across the country. So when we talk about cost of care, we need to subdivide dual eligible dialysis patients, non-dual eligibles, and patients on disability that have Medicare. So the dual eligible cost is not too much different across the country. But when you compare an area with low percent of dual eligible, it's going to look a lot lower per capita. So this is a clarification. We didn't have too much experience on care coordination before, so we grabbed the opportunity with the healthcare reform and with the Medicare Shared Saving program, and we thank you for being one of the father of this movement. And we have the opportunity to come to CMS headquarters at the beginning, late 2011, the time of the final rule on ACO was published, and we hear what other part of the country were doing, especially the group on Philadelphia, in Pennsylvania, Jasinger, and so others. So we make a adaptation, and we start to experiment with care coordination. So we assign a care coordinator in every one of the clinic's participants to start to engage the patients, to make them to come more often to the appointments and so on. Then we focus on diabetes because we have 45% of diabetes. So every other patient is diabetes. So, have diabetes. And of course, with many of the complications, end-stage complications, we didn't have any education on cost of care before. So we learned at that time, that an open heart surgery was $50,000. The amputation, the stents, dialysis patient about $70,000 per year. All of that was new. We didn't know better. Nobody tell us about cost of care or medical school or resident training. So this movement of improving the quality and decreasing the cost for the doctors is a lot of new information, access to data, and that is a big eye-opener. So clearly we focus on diabetes, because focus on that was going to improve the quality of life of our patient and decrease the cost of care across the board, even though it takes several years for that to happen. So we established a ADA-associated, certified diabetes center, and with diabetes educators, start to train the care coordinators on every clinic. We start to see the numbers around in the country. About 20 to 25% of people with diabetes have an A1C above 9, and that's a shame for all of the medical community. And it was no different in our area. Also, we follow the comprehensive diabetes care and the quality measure, paying attention to the blood pressure, to the LDL cholesterol, the smoking status, using of aspirin, and so on. So we start to focus on that, and some of the innovation that we create 1 year later is a common sense approach. It is a diabetes checklist. Basically, we let the medical assistant to review the chart before the doctor come in to look for those parameters. What is the blood pressure? What is the LDL, the smoking? And to put it on the note on red, on big letters. So the doctor knows all mentality need to go away. Let the team to help you out. So when the patient is even coming for a different reason on that day, for back pain or headaches or whatever it is, the doctor have a big red number, A1C 8.5, it need to be taken care of before the patient left the room. And then we really go on the checklist manifesto like a few months ago, and we matched the idea. This is what we have been doing for a couple of years already. It's a very low-cost solution, but it's helping us to great outcomes. Our A1C above 9 came to 12% as a group, but in the teams that are more focused and are using the care coordinator, the nutritionist, and the checklist, it's coming down to a 3% only A1C above 9. So we're getting, with care coordinator, we also have a nutritionist that on that particular day of like half a day per week, we put the uncontrolled diabetes patient to come on that day. So they say nutrition is before or after the provider. So that's a nutshell some of our innovation.
Now, a lot of these programs that you've implemented, the checklist and the ability to track it, I know it was some work to get that information out of your electronic medical records and get it right in front of the doctors in big letters. The screening that you're doing, the nutritionist, the diabetes educator. How is that being paid for now? Does the Medicare ACO program do enough? I know you took some extra steps that most providers in Medicare haven't taken with the ACO program to try to get more money up front and to try to make this more meaningful for your clinicians.
Right, we didn't have the money to do all of this at the beginning, so we took the opportunity on the advanced payment model on the ACO. So the CMS gave us $6 per patient per month through some extra money on front with that we using information technology. We didn't find at that time a good population management software. We have about 7 different EMRs, but the EMRs are still nowadays pretty much a computer note taker, and we need a lot more than that. We need a population management system able to take quality data and to tell the patient this is your Medicare population, 50 to 75, that is missing a colonoscopy or have an A1C above 8. This is your groups. The Medicare records, the EMRs do not have enough filters to help us out. So we got 2 smart IT guys that put together to develop a system to interface with every EMR and show the doctors this is where you are. And doctors are very competitive. Now they want to be in the bottom. So everybody tried to improve.
Thanks for the overview. So now I want to turn to a couple of the payer perspectives. I mean, we've heard from both of these examples how the lack of alignment between some of the innovations that you'd like to implement and the care that you actually get paid for has presented an obstacle, but one that you all are working to overcome. I know for both of you, from the public and private perspective, have not only been looking at new payment models, but looking at other steps that you can take to support these kinds of innovations in care. So Steve, if you don't mind my starting with you, you've got a challenging patient population and a challenging budget situation in Michigan to deal with. How are you approaching innovations and supporting innovations in care for diabetes and other chronic conditions?
Well, I guess, first of all, I'm pleased to be here. Very interesting program. I was trying to figure out how I got invited, and I guess I figured Michigan was far enough away to qualify as across the world. So, but anyway, we have a number of, I think, initiatives that are currently underway that relate to, trying to deal with chronic care in a more innovative way, and then we do have some strategies that we're still working on. So I think a lot of times it's good to sort of see where you are in terms of a point of departure. So if I could quickly cover that. We've had diabetes education programs that are actually certified and I think covered in statute that Medicaid's been paying for I think decades. And so that's kind of a baseline. We are an HMO state, and I think as states are different and regions within states are different, that's part of the challenge, especially like at a state Medicaid program level, is how do you have a strategy that works in a more systemic way, but is still responsive to the individual kinds of innovations and the kind of variance you see in the way care is organized. And so, like I said, we're an HMO state. We've had sort of an all-in strategy on HMOs for about 18 years. And so we have increased the quality. We have hemoglobin A1C testing that's been included in a financial dollar incentive pool that we distribute based on hitting certain benchmarks. It also is included in an auto-assignment algorithm so that HMOs get more lives if they do a good job. And then we're adding hemoglobin A1C control in terms of this incentive pool and that distribution in this current year. We have some grants in terms of community health workers that are relating to chronic disease and trying to expand beyond strictly medical model to other health and social services that impact these conditions. We have a health home demonstration in 3 counties for individuals with severe mental illness, but diabetes is a co-occurring condition and is addressed there. We have the biggest patient-centered medical home project in the country with Medicare and the Blues and Priority Health and some other payers. And so we have more primary care physicians who are affected in terms of trying to transform that model. And then we have the Healthy Michigan program, which is Michigan's version of the Medicaid expansion. And there's a focus on preventive services. There's a requirement that primary care visit be scheduled within the first 60 days and hopefully actually occur within the first 5 months. Co-pays are waived for certain services that relate to chronic conditions, including diabetes, so that would be both physician services and pharmaceuticals. We have a health risk assessment that all of these low-income adults are expected to complete, and then there are incentives if they comply with certain kinds of healthy behaviors in terms of weight control, tobacco cessation, or even just follow through on getting their chronic care, and they can get, if they're over 100% of poverty, their premium reduced, or they can get gift cards if they're under 100%. So that's kind of the framework for where we are, and it's quite a range of models there. But what we're going into is a procurement for our HMO business, and this will be, the RFP will be released in May. And we really want, even though we've been paying full risk capitated care, which has given the HMOs certainly a lot of flexibility in how they pay providers and the kind of initiatives and innovations they have, what we found is they're fairly limited, and fee-for-service still is sort of the reactive way of doing business. So we're going to be pushing hard to pay for value and pay for outcomes. But the question is, how do you do that? How do you do that from a payer standpoint to require that in an effective way? And at the same time, we have the state innovation model, which is a $70 million grant from CMS over 5 years, where we're moving to accountable systems of care in some regions in the state. And we want to be aligned between Medicaid and this innovation model. And it's kind of a struggle to make sure we have our signals straight, to make sure we're both moving in lockstep. And how are we doing that? Is it episodes of care? Is it some kind of global payments or subcapitation tied to certain kinds of behaviors and outcomes? Just what are we getting? So as a payer, I think, there's really a struggle with coherence and alignment and having a more systemic strategy and still being responsible to individual initiatives. So, we have 2.2 million people in the Medicaid program in Michigan. We have a budget of $16 billion a year. So you have to have some consistency, and you have to be able to put the mechanics in place to make this all manageable and to be able to have accountability. And so I just have sort of a series of questions in terms of, what are your strategic goals? Are you focused on a limited population? Do you have a more systemic strategy? Where are you in terms of what's your point of departure? Maybe the system has already really moved you pretty significantly, and you don't have that much to gain. So you have to assess that. If you're focusing on high-risk, high-cost patients, you have to make sure you aren't just having a regression to the mean, that you're actually impactful there in a broader way. And you have to figure out how is the health system organized so that you're capable of executing your desired model. If ACOs are out there, and we do have some in Michigan, but they're not everywhere, then that's a partner we can interact with. But if they need to be developed, then that's another effort, and that would have to move along in order to bring the rest of the state, I guess, into the fold. So anyway, that's sort of, I guess, just a broad way of maybe outlining the
That's
challenges.
very good context and a good illustration of why you're here, to highlight the range of both progress on payment to support innovation and some of the challenges that you still see. So I do want to come back to those, but I'd like to first turn to Chuck for more of you're one of those health plans that's Aetna in the United States is undertaking a lot of efforts around moving away from fee-for-service payment. Aetna around the world is involved in some of these innovative approaches to care delivery. So Chuck, maybe you could provide a bit of an overview of how things look from the standpoint of innovations in diabetes care and other chronic diseases from that standpoint.
Yeah, sure. Well, first of all, thanks for having me here. HealthAgenda is a population health management arm, if you will, of Aetna that enables providers to assume accountability and risk. And over the last 5 years, we've helped develop and manage more than 60 ACOs, about 200 patient-centered medical homes, and we've got about more than 1,000 value-based care relationships that cover about 3.2 million lives. So we've had some growing experience with this. What we find is that providers, although they may be willing, they're not necessarily able to provide all of the capabilities necessary to manage in this kind of model. And so we provide enablement services that are technology and data analytics services, care management services with thousands of nurses and behavioral health and social workers and others that can provide these services in partnership with the provider, either on a centralized or a localized embedded model. And we do this on a payer-agnostic basis across all populations, Medicare, MA, managed Medicaid, commercial insured, commercial self-insured. And so in addition to this, we provide tools for patient engagement. And there are a lot of innovative ways we've found to engage patients that are very different. I think there was a question asked about how do you think about or manage these populations outside of the acute episode, and what kinds of approaches can you take? Some of that comes from the benefit design that provides them incentives through a high deductible health plan or other financial incentives that give them rewards for participating in programs even though they might not have symptoms. Some of those involve certain technology tools that digital and social and game mechanics that provide an engaging way with neurobehavioral feedback loops that reward them for certain behaviors and get them hooked. For example, in competitions to lose weight or to engage. We found that the social approaches with social caregiving are particularly powerful because we can enlist caregivers and other loved ones that provide support for that individual encouragement. With the approach to care management, though, we think of a little bit differently because we know that the cost of care, about 45% of it's driven by 5% of the population that are sickest of the sick. And so rather than think about care in disease verticals, program-centric, diabetes or COPD program, we think about it in terms of horizontally in terms of risk bands. So we aggregate data from a wide variety of sources, claim data, clinical data from a growing number of EMRs, sociodemographic data, patient self-entered information, and physiologic data from biometric sources, et cetera, to understand the population, understand the risk bands and those who are at greatest risk of having the need to consume healthcare resources at some point during the year. And then we reach out and engage those people, and we engage them either telephonically or electronically, or increasingly through localized, embedded, multidisciplinary care teams that would include care coordination, nurse case managers. It would include behavioralists and pharmacists and others working in concert with the provider. We find that when we engage people with these local teams, the engagement rates are about 100% higher than the engagement rates we get with traditional health plan. And then the impact on the cost of care and the outcomes of these people can be substantially higher, as measured by a variety of things, traditional utilization metrics, PMPM cost savings, change in trend from year to year, the quality metrics. We track some 200 different quality metrics and report on those. So it's these kinds of approaches. We've had a number of long-standing ACO partnerships. Banner Health is one I think that's widely recognized, has been responsible for an enormous amount of savings in the Pioneer program. But there are a wide variety of others. We've gotten tremendous results in our Medicare Advantage programs as well.
Thanks. So I would like to come back to some of those payment reforms, like the ACO programs and related programs that both you and Steve mentioned. But it does sound like in hearing from all of you, there's some real common ground with the kinds of innovations in care that we heard about internationally as well. And if there's one big theme there, it's moving to this, and I think as we heard on the last panel, patient focus really isn't enough. It's more of a citizen focus and certainly not a treatment focus or a vertical. Can you all maybe add a little bit more about what you see as you look around in terms of innovations here in the U.S. that we've talked about a bit today, internationally, what you see as some next steps that may help with moving in that direction? You all have taken, maybe I'll start with the two of you who are actually implementing some of these programs with your healthcare providers. So Greg, Jose, you've clearly taken some steps in this direction. What's next? What are some of the most promising further innovations out there in moving to this person level focus?
Well, I can comment. First, I just appreciate Chuck's comments. It sounds like there's a lot of parallels with what we're doing, and I even taken that down to a patient level, multiple examples, even in these small N of patients that we've already managed. But we had one patient with mental health issues, bipolar disorder, personality disorder, literally that was contacting our clinic 20 to 30 times per month. So these interventions, when you really get down to the patient face-to-face or high touches, it's a very intensive process that in the current system, there's just no way those can be managed. So what we do is just let that pattern go on and on and on. We had intensive work with our behaviorist, physician, nurse practitioner with this one patient that literally got that down to one call per week. So unless you kind of get really down into what the details look like, it's hard to understand how intensive of approach this is compared to how we currently do it. So to answer your question, I mean, we just want to expand that and diffuse that type of a model. And really, it's just kind of a changing of the resources and where we put our funding into that type of a team-based approach to really manage this very high-touch, high-need population. And it's hypothetically speaking, with a low end so far, I mean, I've already seen the benefits, whether it's from medication, adverse events or decreased visits to the emergency room or such a dramatic reduction in phone calls and so forth. It's really just kind of a changing of where we put the dollars and where we put the resources.
Okay.
In similar way, we are trying to expand our programs within the ACO. We are trying to share best practice from the top performer units to the one that are new or are lagging behind. We also are getting our care coordinators to call more often the patients, especially the patient with higher A1C, to make medication adjustment between one appointment and another, if the provider see the patient, and increase the insulin, for example, and the patient do not feel secure or do not have the education to do self-titration. Care coordinators call like every other day, every 3 days, increase the insulin, take the extra pills, etc. I mean, there is new great medication on diabetes on the last 4 years, but they are very expensive, and many of our patients don't have even the money for the copayment on that, so this is a challenge there. We are trying to get more sophisticated, trying to use some tools for predictive analytics and predictive modeling and focus on those high-risk population. But our small program is being successful, and we are willing to share, and we are in the top 10% of the country, reducing A1Cs and reducing the whole block of blood pressure, cholesterol, and so on. So we are learning from ourselves, learning from others, and try to grow in South Texas.
Mark, can I comment just on the care coordination?
Yeah, sure.
Jose prompted something in my... I think care coordination, care management has been around for a while, but the other thing that we're seeing with our care coordinators that we have currently working is that we're actually looking at them as a care coordinator throughout the process of the whole horizontal flow. So already we've had care coordinators accompany patients to their specialist visit. So for health literacy, interpreting what that visit really meant, what was the feedback, what was the plan of care. And just recently we had for a very high utilizer for ER and admissions, had a health care coordinator and nurse practitioner visit that patient when they were in the hospital. But that was an ambulatory connection because that patient kept showing up back in the hospital. We're able to find out some social things that were going on and actually put some of those things in place. So I think we're kind of wanting to take that care coordination to a next level. It's not just in an ambulatory setting, but it's literally following that patient through their entire journey.
Just
More
to
from
add
Jose.
one line, in similar way, we are doing a lot of home visitations by nurse practitioner, PA, when the patient comes out of the hospital, and our nurse. This is very, very important piece that I have not mentioned before, the home visitations.
And Steve, Chuck, in terms of next steps, maybe unmet but promising opportunities for further innovations in this person-focused approach to care that can improve outcomes and reduce costs?
Yeah, sure. There's, I would say that of all the innovations that are occurring, there's probably 5 areas that I think that are the most promising. One of those is in social caregiving, so that you enlist not just the patient, but the team of their own micro network that cares about them. We did a program with neonates that engaged the family and other support around that with using technology and iPads, and found a pretty significant drop in both the average length of stay in the NICU, post visits, and days lost from work for the parents. Another interesting and exciting area is in biometrics and integrating biometric data sources in the care of complex patients so they can remain independently managed out of the hospital for a longer period of time, and that's integrated into care management programs. A third area that has been mentioned a couple times here is a team-based approach to local care management, but focusing primarily on transitions in care, complex case management, and end-of-life palliative and compassionate care, and particularly integrating behavioral health in those. Another exciting area, I think, is in advanced analytics that incorporate now data way beyond the claim sources to better understand the patient. And then the fifth area is in patient engagement, new modalities using digital, social, game, and other types of ways to engage individuals, and also to use sophisticated socio-demographic targeting to understand which engagement modalities are going to be most effective. It's one thing to call, let's say, a 55-year-old housewife on a telephone between 8 and 5, but that's not going to be effective with an 18-year-old that doesn't have a landline or a 75-year-old person that is incapable of answering the telephone. And so we found that there are about 8 different socio-demographic patient groups that each one have unique and different ideal paths to contact them. So if you actually channel those engagement methodologies using those socio-demographics, it can be far more successful.
Well, that was a fantastic answer. So I guess just maybe a general comment, and that has to do with, because I think there are many opportunities given technology and EHR and some of the opportunities that really technology is affording us in the future. But I guess my comment has to do with sort of a dilemma about resource allocation. I think, we're sort of an instant gratification culture, and certainly, we want to see dividends quickly. And so I think the high payoff obvious programs are those where you have costly patients who have, many different kind of exacerbations. They have they need a lot of services. And so there are very significant costs, and if you put a program in place and manage them better, you're going to see a payoff in relatively short term. I think what's interesting from my standpoint is what happens with programs and can they be sustained where the investment is long term. So for our Healthy Michigan program, we have a health risk assessment. We have healthy behavior emphasis, and we don't know how that's going to work because we don't know how human beings are going to respond to this, and it seems like this is an area that needs a lot of work in terms of gaining evidence to find out what the best mechanisms are to incentivize people to live healthier lives. But, is that going to be effective, and will we hang with it long enough so that we can see the payoffs down the road? Because if people do eat better and have better weight control and don't smoke, you're going to see a lower incidence of diabetes. So you really are getting upstream. But I think, do we have the patients for that? Will we allocate the resources there and stick with it long enough rather than having these models that are built around high cost, high acuity populations where you can kind of see the results much more quickly?
Let's turn that back to Greg and to Jose. So you all have been doing more upstream work, and we heard about it in the first session this morning too, about outreach for screening for patients who are at risk for diabetes. And Jose, you talked about the diabetes checklist and the other steps that you're taking to try to get, both of you, steps that are trying to get evidence-based care followed for patients who have been diagnosed with this condition. Do you see that moving further back upstream? It certainly can have an impact on health and on cost, but as Steve was saying, it's probably going to be a longer-term process than being able to show that the impact on diabetes complications and the improvement in outcomes and preventable complications, really within the next, sounds like you're seeing that pretty quickly.
Well, yes, I think that, again, it's the investment on diabetes care, it takes longer term to pay off, but the same intensive approach to engage the patient pay off in shorter terms. In the quality of care and in the cost side, in our group, we have like extended hours. We have a Saturday morning clinic. We have some evening clinic open 7 days a week and so on. So I think that this is different pieces moving together with a common goal of better care, lower costs, and again, different modality working in different areas. We are trying to use a low-tech, low-cost approach, and it's working in our view.
Yeah, and to Steve's comments about sustainability, how we make this work long-term, again, for us, the 5% is the tip of the spear. We start there, but I think in order to make this a long-term success, and even to Chuck's point, as you go down the pyramid of risk stratification, the low risk or no risk are going to be interacted with in a much different way, and I think it's using best practices. I think I've collected about 5 articles in the last couple of years on, the death of the annual physical and, why are we expending resources on doing things like that. So I think in order to make our resources work at the tip of the spear, we will probably, divert some of our resources that are now probably over-utilizing resources and put them into the, the benefit of helping manage so we're kind of working our way down the pyramid and trying to come up with the innovative model for the whole 100% of the population and to the stratification of, those socioeconomic stratifications and social, dynamics. We're going to be looking at that as well.
Yeah. Just to add one line, we need the Congress to put, to continue the effort for this to work in the future. So the payment reform need to continue to happen. Moving away from fee-for-service, adding like partial capitation, full capitation, and the payment for chronic case management that CMS recently approved is a step on the right direction. But we need a policymaker to focus on that. And a little thing, like when you go to a restaurant, it should have how many calories you're going to eat in front of you. Some cities are starting that, but that should be spread around the country. And also limit, like in California did, the number of fast food restaurants in a given city, taking the whole population.
Well, let me, you're talking about going more systematic. So we've heard about a lot of innovations in care. You all touched on many of them here, and in the first session, we could go on about steps towards earlier and more efficient screening, steps towards more effective outreach, and ongoing management support, ongoing support for patients with diabetes or prediabetes to prevent complications. Talked a lot about team-based approaches to care. I guess you all haven't gone so far as to train Ayurvedics as nurse practitioners, but that general direction towards more efficient team-based approaches to care, very common theme today. But I guess another common theme, just picking up on Jose's last comment, is the need for further payment reforms to support these efforts. You started with that, Greg, at the very beginning. And maybe we could just spend a minute, and I want to open this up to comments on from the audience on what you all see as the most important innovations that need to be furthered in terms of payment reform, benefit reform to support these kinds of efforts.
I have a comment about that. The trend that I see is health systems and providers increasingly want to get to a percent of premium or some other type of a global payment. and in many cases launch their own health plan. The focus on the sickest of the sick is a little bit of an artifact of the way that we're paid under, say, MSSP and others, where you have to generate savings. And the best way to generate savings is go after the sickest of the sick. And you're not going to generate short-term savings by focusing on diabetics. The payment system has to be a lot more global than that. I mean, there has to be a share of savings, but there also have to be incentives for doing preventive things. There are meaningful incentives. We're finding, though, that a lot of health systems want to get to capitation fairly quickly. And I think that that's the logical next step, because fee-for-service is the biggest problem that we have right now to incent overutilization of the system. But managing capitation is actually not that easy. I mean, it sounds simple, but as every health plan knows, if you price wrong, you lose your shirt. And so it's all about pricing to cost and pricing to trend. And many health systems don't know what their costs are. They don't have activity-based financial accounting systems. They're guessing at best, and many of them there's a wide variation in efficiency. Some of those that are important resources in the community under fee-for-service model might go out of business under a capitation model, and it shouldn't necessarily be our goal to drive quality healthcare providers out of business. The goal should be bringing them along so everybody can be financially viable if they're a quality provider. So we want to get to capitation. Administration of it is difficult. But there are more and more systems that are stepping up to want to do that. And we find a lot of systems coming to us wanting to partner in joint venture health plans. And I think that that's going to be an increasing trend.
And that's kind of a shared risk, not all the way to capitation, but kind of certainly a different role for providers and health plans in working together. And Steve, maybe I could turn to you. As you just heard from Chuck, a lot of healthcare organizations don't know about costs at the overall patient level. As Jose said, that's not what we learned about in medical school, and that's not what the data systems that are available provided. But they also don't know about the range of innovations that are available and their likely impact and how they can be put together effectively. And one of the things that we heard in the first panel was some of the steps that are taking place to support that. That includes payment reforms that are more person-focused, whether it's subscription models or capitation. It includes more public awareness and transparency around meaningful performance measures and the like. And it reminded me of your comments at the beginning of this session about, gosh, there's a range of things that you're trying to do to get what seem like capitated health plan payments on the surface to get more towards what I've just been hearing about from Chuck and the healthcare providers on this panel about translating that into on-the-ground support for real innovations in care, real transformations in care using the kinds of innovations that we've described. So maybe I could come back to you for just a last comment on this. Any further thoughts on how the range of initiatives that you're undertaking to move in this direction can fit together to accelerate innovation?
Challenging question.
Yeah.
Well, I think the reality is that fee-for-service was sort of it just was sort of, I can't think of the right word, sort of a reflexive way of approaching. Really the only way that was sort of established that seemed to work for everybody. And so you had shared savings built on fee-for-service. And so we really do want to push away from that. I think the question is, what is really going to work? And I think we know some things, with the models that we've seen and heard about that do work. I think the question is more, what would work in a really systemic way, across the board? And, is it really focused on outcomes and trying to incentivize and pay for behaviors so that, you see the evidence of a certain number of preventive visits or whatever it is that you're trying, diabetics that are under control, whatever the metric is that you're shooting for, or is it more on the financial side of looking at the total cost of care and how that total cost of care can be reduced so that you have a subcapitation or capitation arrangements where there's a more global budget type of approach. And I think actually we're just trying to wrestle our way through that, but the reality, at least for us as payers, is that I think we realize even though we had a full risk capitation arrangement with HMOs that gave them complete flexibility, the reality is it's very hard for individual organizations that are intermediate organizations to change the system. And so the fact that the federal government is pushing ACOs and that now at the state level we're pushing accountable systems of care, essentially we're forcing the provider system and the organization of providers to change. And I think we're saying to physicians, you've got to group up. We can't figure out how to incentivize you as an N of one. You can't do the risk adjustment at the level you need to in order to be fair there. So you're going to have to be part of an organization, and so hence these accountable systems of care. And I just think that's what's got to happen in terms of the fabric of the organization of care, and the way the financing works has to change in order to facilitate all of this.
All right, I'd like to open this up to a few questions from those of you here in the room and online. As before, if you've got a question, please raise your hand, and we'll get a microphone to you.
Hi there, Anna McAllister-Slip. I have type 1 diabetes, and I do health data analytics, and I'm also a huge policy nerd and live 3 blocks away, so here I am. One question that I have as I listen to all of this, it still seems to me that, and I know we're talking about population health, and that's sort of the nature of this panel, but it still seems to me that everybody's focusing on what the system can do to manage patients, as opposed to actually putting the responsibility and the opportunity in the hands of the patients. And I feel like, especially if you're looking at type 2 diabetes, both my parents have type 2. I mean, as do 90% of the people with diabetes. If you're looking at how do you prevent type 2, how do you do secondary prevention even once a diagnosis is made, that ultimately the model needs to flip, where I see my physicians as consultants. They don't manage my care, I do. And I think that until we get to that model, we're still going to have cost overruns, and we're still going to have people hitting complications. And as somebody who, again, is a little bit of a nerd and watches this stuff, I've been a little frustrated that there haven't been more incentive-based sort of cost-sharing, risk-sharing with the patients, not in terms of giving them more cost, but giving them more benefit if they actually meet biometric measures, or go to the gym every day, or weigh themselves every day on a digital scale. I mean, there are lots of things that we can do now with technology that we couldn't do 5 years ago, 10 years ago, and I don't feel like that's happening or being incorporated into these new models that are emerging in a way that could be far more innovative and game-changing than what we're seeing.
That is, in fact, the model that now is fairly typical, deployed by the parent company, Aetna, with the high deductible health plans that are person-centric, with incentive and reward systems. In fact, we administer a lot of those reward systems. So if somebody has a metabolic syndrome, or they're pre-diabetic, and they are given, it's brought to their attention that here's a weight loss program for you, or here's a smoking cessation program, or something else, and then here's some incentives that you will get if you enroll in that, if you do the assessment, and so forth. And they can, in some cases, make hundreds of dollars by doing that. Now, for some individuals, that might not be meaningful, but for many it is. And so these, I think, are becoming increasingly common. But it's a great point.
Thoughts?
Well, I just wanted to echo, we'd love to have all of our patients, be like you, and I think to the point of actually understanding each, understanding each individual, because what we're finding is patients that we would just write off as non-compliant before as a provider. When you get under the hood and understand really what their barriers are, it is, most commonly around socioeconomic or psychosocial. So that's actually one thing we're trying to do. There are assessment tools where we can, with each individual patient, kind of assess their readiness to engage. And then if they are ready, that's where we would spend more time and effort. So we are trying to move more to that model of understanding, what does motivate an individual, what are their barriers that may be out of their control. And where healthcare probably didn't venture much into the community-based efforts, that's what our care coordinators are trying to do. So if they do find, socioeconomic problems, like we had one patient that was homeless, so not likely going to engage in, medications and taking things, and so we had to find that out and then help them find a way to alleviate that burden before they could even get to the care portion. So it's a great question, and I think a lot of people are very interested in finding out better ways to do that.
Yeah. And if I may make a quick comment, when we were designing the Healthy Michigan program, the assumption that was made, by some of those designing it in the legislature was that if you have a financial incentive, it'll move people. And then we engaged with behavioral economists who actually study this stuff and could give us some information about, what they had learned in the field. And there's an awful lot to learn, but it just seemed like it was kind of discouraging. You could move a certain percentage, but really not that big a percentage, even in an employed, commercially covered population with dollar incentives or with other kinds of incentives. And I think the real dilemma here is what does move people, and when you're thinking of a population, how do you know? Because you get a variable response. If you do something and you say, we'll give you a couple $100, you might get 25% of the people. That leaves 75% that you didn't. And I've always thought, well, and I mean, I have my own failings, but why do you have to incentivize anybody? What's more important than your own health? Why should you have to pay people for this? And yet, we do, and it's not illogical, but the question is, but there's so much more to learn here, and I think it's so hard. We haven't figured this out in terms of how to engage the consumers effectively. I mean, we talk about aligning the incentives between providers and consumers. I think that's the right thing to do, but I just think we have a lot to learn.
Jose, you're dealing with a lot of patients where you can't really charge them high deductibles or things like that. People with some really limited resources. What's
right? I mean, it's a good point, but as Greg mentioned, the educational level of the patient, is different from one point to another. In our case, it's very challenging, and we are glad that CMS is considering in some of the next generation ACO model. And probably plan for the future in ACO, like to waive copayment for the patient when they go to high-performing ACOs or high-performing doctors. That's an incentive right there. I mean, it tells the patient, okay, you don't have to pay copayments if you go to the people that are really going to control your diabetes in one way or another, working with you. In our case, the engagement has been more the phone calls. Some of our elderly, the only social contact that they have pretty much is the our care coach. It's a 9 o'clock phone call that they are expecting. They are their friends. Right.
We have time for one more quick question. Zena, if you want to go ahead.
Thank you for the fantastic panel. I think it was really good. And, coming from India, so as a country, we have been aspiring to move towards, capitation models for a long time. I don't think we are ready as a country because you need like a basic framework and infrastructure to get there. I see a lot of emphasis over here to move there. I was just thinking that, you made a point saying pricing is really the most critical thing. And if you get it wrong, it can be seriously wrong. I'm just thinking, I'm sure there's a lot of literature on this, which I'm not aware of. As you make this shift from fee-for-service to capitation, how do you see it impacting your overall healthcare spending? Do you expect it to remain the same, come down, go up? I mean, it would be an interesting correlation to look at, and if there is any evidence or speculation on that.
It is. I think several of you emphasized that because of the way that some of these payment reforms are being implemented now around shared savings, the expectation is that, we'll take some steps in this direction, but save money at the same time. And I think there were some comments that wasn't really enough of a shift towards person-level financing. So any brief thoughts on Zena's question?
A couple of thoughts real quickly. With the ACOs that we set up, we have actuaries that crawl all over those systems. And we try and end up with a product in the marketplace that's between 8 and 15% below what the broad network cost of care is. And in general, we hit those numbers. And it's done through a combination of the efficiency enablement services like technology and care management, but it also has to do with providers just being willing to lower their prices, because they want to pick up a greater population to serve, and that means that they have to provide an incentive for people to want to shift, and they do that through price as much as anything else. So I think those kinds of things over time will have an impact on the market in general. So where we've come out with an ACO network or product that's been 8 to 15%, we'll find our competitors follow very quickly by dropping their prices. And what happens is that there's a market effect where the price growth is blunted just because of the introduction of these models.
I just comment on that as well. I mean, when I talk about a readiness and willingness from a healthcare system, I speak of it really from the healthcare system only. We still contract and work with a lot of independent specialists that are probably much further away from even being close to a mindset of a value-based payment model. So we're still trying to get people, even though they're in our ACO, there's still a lot of education. They're holding on to the fee-for-service as long as they can. They're small businesses. They want to maximize income. They can still go out and build their own independent freestanding things, which is probably a whole nother policy discussion. But so I think as an aggregate, we're still a ways away, but I think from a health system where we're already performing fairly well, unless we get to that point, it's just probably an unsustainable model until we match up the delivery with different payment methodologies.
sounds like very much a work in progress, but some interesting lessons and experiences both here in the U.S. and abroad in moving this direction of disrupting diabetes care and finding ways to make that sustainable. We are going to take a short break now before turning to our final panel, which will go back to a global perspective, putting together what we've heard in the two panels so far, plus a perspective from Agnes Sukat from the Africa Development Bank, working closely with the World Bank on, again, a global view on some of these issues in innovation and systematic improvement around diabetes care and more generally. But right now I'd like to thank our panel, our second panel, for a very interesting discussion of some very important innovations in diabetes care and care for patients with complex diseases. Thank you all very much. And we'll reconvene at